Hello, students. We are now going to explore joints, chapter 8 in your Essential Science book. So chapter 8, let's open that one up, is the second chapter in our kinesiology section. And we just went over the bones, the skeletal system, and now you've got to connect those bones and come up with a variety of different kinds of joints depending upon the shapes of the bones. So let's get rid of the table of contents here. You already know how to work with the features of the textbook, so let's get right to work here. Again, your key terms, pay particular attention to the key terms in this chapter. They are very likely to show up on the MBLEX exam, and their common terminology in manual medicine, massage therapy, chiropractic, orthopedics. This is a language that you need to have, speaking more fluently with this language. Learning how to learn. This is this joint movement chapter is a palpation movement strategy. Palpation and movement while you talk yourself through it is an excellent strategy. And you'll see how the chapter is designed for you to be able to do that. So as typical, here is our overview. And some fun little statements about joints, like a joint cannot exist with only one bone, at least two must work together. Joints and muscles need each other. Joints must move to be healthy and function, and they are best designed to move while muscles function effectively to produce joint movement. So a name for a joint is also an articulation, and there's a really important concept here in joints, the balance between joint stability and joint mobility. In our health and wellness, we've talked about in societal approaches to health and wellness, they talk a lot about flexibility and a lot about stretching. And now we're starting to realize that, especially with the chronic pain concept, chronic musculoskeletal pain, sometimes the underlying reason is too much flexibility, hypermobility. And if there is instability in the joint structure, then it is common for the soft tissue structures of the fascia and the ligaments and the tendons and the muscles to actually shorten and become more dense around that joint to provide the stability that the joint structure itself is not providing. There are simple joints and complex joints as well, and the simplest human joints are less mobile and more stable. And then the more complex joints provide mobility and are less stable. So the joints in the axial skeleton are typically more stable and less mobile. The amount of movement is small. But in the limbs, the whole upper limb and lower limb and hands and feet, the joint structure is more complex and are less stable. So it becomes really important that we have a balance between stability and mobility. There's a couple of different kinds of stability here that's talked about here. Form and force. Form closure, form stability is how two joints work together. They fit tight. And so the joint itself provides a level of stability in addition to the structures around the joint. Force stability. So that's form stability. Force stability is where the joint is more loosely connected. The bones don't have quite as big a connection. They're not as tightly fit together. This obviously is going to allow more movement, but there's also inherent instability in the joint structure with that. And so it relies on external structures like uh, a, a more firm capsule and the ligament tendon structures and the way the muscles come in around the structures of the joint to hold that more stable. Force and form. And here's a couple of pictures of that. This is form, and this is force, stability. They call it a closure as well, form closure, how the joint closes. See, it's the shape. And then here, you've got that looser connection, but you've got to rely on external structures to make sure that you've got stability. Do these activities, they are retention-based activities. This one is asking you to provide an example of joint design. So I usually, again, will provide an example. Again, you don't have to spell right, all that. This is a learning activity. And then connective tissue is a very important part of how joints are structured and then how they work together. And it's a more fibrous, stronger type of connective tissue. And then inside the joint, you've got a collagen-based, the mobile joints, you got a collagen-based sliding surface in through there. So elastin is around, but most often elastin, collagen is more common. There is more collagen within a joint structure and the soft tissues around it than there is elastin. So ligaments are what join the bones together to form a joint, and they're primarily collagen. There's a little bit of stretch in there, though, a little bit of give. Tendons, on the other hand, are a little bit more stretchy, just a little, not very much. The tendon ligament complex around a joint works together, beds right in the kind of the balloon around the joint. The two bones together called the capsule. They all provide that space. They keep things far enough so that the joint can move, but it also provides a containment and stability. Bursa are little fluid-filled pillows strategically placed where if something is going to rub, it'll rub over top of that bursa area. Now that bursa can get inflamed, and that's called bursitis. And I mentioned the cartilage here. The cartilage that is between the bones that provides that smooth sliding surface is hyaline cartilage. So here's kind of a schematic. Here's the articular cartilage, hyaline. And then here's a synovial membrane, and it creates a synovial fluid. It's an egg white consistency, and it actually keeps the bone ends apart just a little bit. So, and it keeps this cartilage lubricated. So here's an example of how the ligaments come on in and become part of this capsule that forms from all these tissues around this joint. So the viscoelastic property of connective tissue has to do with how stretchy it is and how dense it is. So a structure that is viscous, it's thick, it's if and stiff if it is not moved. But if it's moved, I think silly putty or clay, if it is moved, it becomes more elastic and more pliable. So the connective tissues around joints become more uh, uh, pliable when they're moved, and it stiffens up a little bit when you are still. And that same action will become stiff if there's underlying joint instability. It's part of a resourceful compensation. So the plastic range in terms of how much movement you have in these connective structures in a joint is what's called the plastic range. And just like with a rubber band, you can pull it and it'll come back, and you can pull it and it'll come back. But if you pull it beyond its give, you pull it beyond its give, and you keep it there, especially if you keep it there, it's going to deform, and it's going to become that length again. It's going to lose some of its elasticity to return. If that is abrupt, then you can get a tearing of the structures. And if that is a ligament, that would be a sprain. So here I've talked about laxity again. Slow down, pay attention to that, and the idea of shortening and stiffening. So here is a example. This is a problem solving activity that's also a retention activity. And it's going to give you some assessment principles for too much movement, hypermobility, and then hypomobility. And then it's going to ask you to take a look at that and problem solve that. The soft tissues of the body, the whole body is actually has to be able to respond to mechanical forces acting on the body from the inside and from out. So massage is an application of a mechanical force to the outside tissues of the body. But when we move a joint back and forth, we get both an internal force pushing out, and if we are pressing on it, then we've got a mechanical force pushing in. So that's what external and internal forces are. And then when mechanical forces act on these tissues, that they're said to be loaded. The tissues are loaded, and that loaded tissue creates a stress in the tissues. And the applied force, that's what we do, is going to load the tissues. The tissues are going to change shape, which is typically they're going to deform, and that stresses the tissues, and then back to the nervous system. The nervous system receptors, the proprioceptors, the mechanoreceptors in the area respond to that. And then you've got changes in muscle tone, or you'll have changes in tissue density. You'll have tissues, muscle tissues across the joint might change in tone in order to respond to this change in a stimulus. So, language used then in the entry-level analysis project works with this idea of force application. You would have had this in your fundamentals textbook, and we would have been talking about this from the very beginning, but here they are as a reminder. Again, part of that relationship between the two textbooks, as well as the idea of spiraling and scaffolding. So slow down, pay attention to this, and relate it to what you know now with massage therapy. Okay, so this you would not typically find in a more academically college-based anatomy textbook. So this is unique to massage. This is one of the good, the really great features for learning anatomy and physiology from essential science. Okay, then we're going to talk more about how these forces will deform the soft tissue. And then these are created by the massage methods that we use. Okay, so once we've got that overview in place and we understand the connection between bones, bony structure, the application of mechanical forces, movement, joints especially the synovial joints have to do with movement as well as stability. The interface between the connective tissues and the muscles and all of that. Now we're going to narrow down and we're going to look at some terminology related to joint categories. And you heard my sigh here. There are kind of multiple names for the same thing here, and you just got to deal with it. You're going to have to know this. So joint categories are divided into three categories related to the type of motion. So synarthrosis, amphiarthrosis, and diarthrosis. The ones that we move with joint movement primarily are these diarthrotic synovial joints. So we're going to look at least movable to most movable. So fibrous synarthrosis. Here's some examples of those. And there's a little teeny tiny bit of movement there sometimes, but it's very limited by that fibrotic stiff tissue that connects the the bones together. Pay attention to your legends when you read these. That'll give you an idea of what each picture is. So these are all types of fibrous joints. And this is A is a syndesmosis, amphiarthrodial, slightly movable. B is a synarthrodal, immovable. The sutures, once they come together in the adult, and then like an amphiarthroidal is a tooth that goes, it's a peg that goes down into a cavity. So again, you're going to have to slow down and pay attention to this language here. This is I didn't do it. I didn't create this language, but it is confusing. And I do have some videos, YouTube videos posted for this chapter that reinforce this language here. So a cartilaginous joint moves a little, not a lot, but a little. Whereas these 10, once the body is matured, these tend not to move. These move a little bit, not a lot, but a little. So a symphysis is where two bones come together like the symphysis pubis down here. And a synchondrosis has a teeny little bit of cartilage in there, so there's a little bit more movement. Sternocostal joints, where the ribs come in, sternal, costal's rib. So there's a little bit of give in there. And then the highly movable joints, the synarthros, the diarthrotic synovial joints. And you've got to be able to use or recognize, you need to be able to recognize multiple names for the same joints through here. So again, this is an example, this is a schematic of a synovial joint. This happens to be the knee. So you're going to want to look at these and see how well you recognize the terms. And if not, you're going to want to narrow down and review. I've already talked about the joint capsule. I doubt, it's possible, but I doubt that you're going to have to discern the specific layers of a joint capsule, but just kind of make sure that you're embedding this language with maybe some multiple reading. Synovial fluid, that's the fluid inside the joint here. And that is unique. Synovial fluid is unique to the synovial joint. And it is the membranes in the joint, inside of the joint capsule, that produce synovial fluid, and it is the movement of the joint that spreads it around and pushes it in and out of the articular cartilage, the hyaline cartilage. I think the section summary here is really helpful to reinforce these joint categories and the language around the connective tissues. Now, orthopedists work with joints, chiropractors work with joints, physical therapists work with joints. So we do have to have a strong working knowledge of the language here if we're going to work in an interdisciplinary clinic, for example. And I can't imagine in the future that we're not going to have a lot of overlapping interactions with others that are involved in manual therapy approaches or focusing on the bones and joints and muscles. So here's joint motion. And here are the subcategories that we're thinking about. And then, so we have arthrokinematic movement and osteokinematic movement. So the arthro, joint, that is the movement that occurs inside the joint capsule. So it's usually a spin or a roll or some sort of translation. It's secondary to the movement that is produced by the muscles. Arthrokinematic movement, this is the one we think about when we are doing joint movement assessment or joint movement intervention. This is, flexion, extension, adductions, and so forth. So here's more on the movements that occur inside the joint capsule between the bones. And in order for that to happen, you have to have just a teeny little space in there to have this accessory movement, these movements inside. So that's called joint play. More than likely on the MBLEX exam, you're going to find content or questions related to the osteokinematic movement. So here again, we have got anatomical range of motion, physiological range of motion. So this is the limits of the bone and tissue structures. If you go beyond anatomical range, you're going to get into where the tissues are going to be stressed beyond what they can adapt to. So to prevent that from happening, the injury that occurs with that, we have a physiological range of motion. So this is usually a little less than what the anatomical range is. And then if a person is not able to move into a functional physiological range of motion, then it is said to be pathological. And the two types of pathology would be hypermobile and hypermobile. An end feel is where the structures of the joint want to stop you. And if you have a soft end feel, it's has a little bit of a give to it at the end. There's no pain associated with it. It's within the physiological limits of range of motion of the joint. Then it's said to be a soft end feel, and this is normal for most joints. That's what you want to find. If it feels clunky in there, a hard end feel. Now, there are a couple of places that's normal. The extension of the elbow is a hard end feel. But if you feel it any place other than that, then that would be an indication that there's something becoming pathological in the joint. Capsular end feel feels stiff. And then we've got a springy block. That feels like there's like nothing in there. It's really loose inside the joint. And then approximation, this is where the soft tissue structures around the joint bump into each other and limit the movement, not the actual joint structure underneath. So you'll find that as well. Then we have places where the joints are more stable and where they are looser. So that's the closed pack or locked position is a stable position. And the loose packed or unlocked is what has to happen if we're actually going to move. But it is also, there's more space inside the joint, and it is where the joint can be vulnerable to giving out or some sort of an injury, but we absolutely have to have it or we don't have movement of the joint. In the closed pack position, if there's an external blow like this, again, this is a knee, if there is a kick or an external force that comes in the locked position, closed pack position, there can be significant damage to the area. So the loose pack position in general is you take a joint and you take it as far as it will go within the physiological range and as far as it will go, again, in the opposite direction in the physiological range. And the loose pack position tends to be right between the two. And that's a place where lots of times we want to have the joint when we are working with massage is in the loose pack position. Here is a more specific detail on what that is, but what I just showed you works in most instances. And then here is that closed pack position. Almost always these are in an extension or a tight fit position of the bones within the joint capsule and maximal tension on the ligaments and tendons and muscles around the area. The way to get a sense of this is to actually move yourself and go, okay, subtalar loose pack position, closed pack position here is supination, or inversion, eversion, that area right there, or the hip, full extension and medial rotation. Actually move yourself through these. So when we get into the actual movement of the joints, this is where we get into, already mentioned, but this is when we get into the planes of motion. And the frontal plane, coronal plane, two names, is where abduction and adduction occurs. Sagittal plane, flexion and extension, and then horizontal plane is your rotations. Terms describing joint movement, make sure you know these. And then here's some examples. And then this is where we start to get into the idea of measuring available range of motion. There's a little bit of controversy over the terminology. Their range of motion is the measurement, not the action. The action would be flexion or extension, and then how much movement is there is the range. But sometimes these terms are used interchangeably. Some people will use the movement to say range of motion, when it really technically should be a joint movement, and then how much it moves is the measurement. So find the definitions of the joint movement in chapter 3 and compare them to what you just had here in this chapter. This is a way of spiraling the information. And then here are the individual classifications of synovial joints, specifically the diarthrotic joint. So again, some joints only work in one plane, and they're called a uniaxial joint. Joints that might work in two planes. So a uniaxial joint could only go flexion and extension, for example. The elbow is an example. A biaxial joint can go into adduction and abduction and rotation. It can go in two planes of motion. And a multi-axial or triaxial joint can go in any of the planes of motion, or a combination of that. All right. Lots of stuff in this chapter, I know. And so here's a terrific picture that gives you a schematic of this, and then an example on the body. And then joint function works in units, it works together. So you can, if the distal end of a joint, like my hand here, is open, it's not pressed against anything, then each of the joints in my arm can move independently. But if I have that pressed against something, like when we're doing massage, now the wrist and the elbow and the shoulder all move together. They're all one unit. So a closed kinematic chain is where all of the joints move as a unit. And an open one is where you can just move one joint at a time. But the distal end has to be open, it has to be free. It can't be touching anything or pressing against anything for that to happen. Okay. Phew. So here is your mentoring tip here. And this one is just kind of reflecting on how intricate and how amazing the movement of joints are. Now, this next section is going to take you through all of the individual joints, and I'm not going to slow down like I just did with all of these principles. The content around the joint works for itself, and there will be a lot of uh, joint movement resource material, and we'll discuss this as we include joint movement into the massage. So, but I do want to show you how it works, how the segment works. So we have a jointed area. We have the names of the joints. And in this situation, the temporomandibular joint moves, but the cranial sutures do not. And then it takes you right through a palpation. And I strongly, strongly, strongly encourage you to do this. And then as you are practicing massage, or if you have a model skeleton, it's really helpful to actually touch these things. And often what you're going to palpate are the bony landmarks. And the other thing I suggest is that you do this out loud. You say this out loud. And another strategy is to actually have the read aloud feature work, but slow it down so that you've got time to move from one structure to the other while you're palpating. There's a picture, and then here's the temporomandibular joint, the bones that come together, the type of joints, and the names of the ligaments. And there are a lot of ligaments. And you do have to have a working knowledge of those and recognize them. Fortunately, most ligaments are named either for the joint or the bones adjacent, so that's very helpful. And the joints also are typically named for the bones that connect. So this is the temporalis and the mandibular bone. Shoulders of the joint, glenohumeral joint. The glenoid fossa is part of the scapula. So are you starting to see why it's important that you have these bony landmarks and understand the structure of the bones? The two bones that come together are the humerus and the scapula. Touch them. This is a synovial ball and socket joint. That means it's a triaxial or multi-axial joint. It moves in all of the planes of motion. An idea of the ligaments, and then a picture to study. Here's the sternoclavicular joint, sternum clavicle joint. The picture. The acromion, that's a bony landmark on the scapula. Acromioclavicular, those are the two bones. And then interestingly, the relationship between the scapula and how it slides on the ribs is a pseudo joint, and that's what this box is describing. And then the palpation. Say it out loud. Touch it on a skeletal model, touch it on a family member. Move it around. And away you go. It's the same pattern over and over and over. This takes repetition. You can click on the picture and make it larger if you want to see more of the structure. So this is an example of how you can make an educated guess at the names of the ligaments in the area. Here's the importance of the bony landmarks. Here's the palpation. The knee is pretty interesting. So this one slows down and gives you an actual box on the complex knee. And you can see how much more there is to touch and move with the knee because of its complexity. And the joints of the ankle and foot. You got to be real committed to this. This is, once you understand the overview that I slowed down and paid a little bit more attention to, then this is similar to the bones and the bony landmarks. You have to just really have multiple ways that you're going to look at and review this information. The joints of the spine are different than the synovial joints. So you want to kind of understand that these are less mobile. Some of them are considered synovial, but the intervertebral disc joint, that's a cartilaginous symphysis. So if you can't remember what that is, you're going to have to relook that up. Zygophosphoceal. That's probably why they call that a facet joint. This is where the ribs come into the vertebrae. Oops, I'm wrong. And I can be. This is where the Lego structure of the ribs or these vertebrae click into each other. They click into each other. And then the various ligaments through here, and the ligaments in the spine do provide quite a little bit of stability. The thorax, of course, this is important because this is where the breathing is going to happen. And there you go. Now, again, unique to this particular textbook is we're going to work on incorporating this information into a massage, and joint movement as a part of the full body massage approach is very, very important. Additionally, it becomes your assessment, and you can narrow down with it for an intervention. So this is the range of motion of each joint. And as a reminder, it's what determines these movements is the shape of the bones that form the joint, how taut or lax the connective tissue is around it, the length of the soft tissue structures, including the muscles that act on the joint, and whether the joint is moving independent of other joints, open chain, or if it's moving in combination with in other movements when the distal end is fixed. So that's closed chain. This is a box that gives you some metaphoric examples of this. This is starting to work us into the pathology. Talks about active joint movement, active assisted, resisted, passive. These are terms you need to know. So the box slows you down. And then how are we going to integrate that into massage? And then here's the specific pathological condition of joints. And you're likely to potentially encounter this type of content on the MBLEX exam, but it's even more important that you're be able to understand this in communication with the client telling you that they've got bursitis and cueing you in to look up even more information than what's in the textbook when with your indications and contraindications. So here you go. Here we are going to look more at hypermobility. Again, there is an increased recognition of this situation related to connective tissue changes uh, and how it is interfacing with a lot of other conditions. It's also why excessive stretching and caution using stretching, joint movement within the physiological and or client's comfort range would, if the joint has pathological changes, it would be within their comfort range, is okay. What you don't want to do is push it beyond the normal range. If the normal range for something is 90 and a little, then that's good enough. You think about it in terms of what is needed for activities of daily living. And this can get compromised if somebody is doing a performance, like a dancer is going to, or a gymnast is going to have created in their body hypermobility and extension of the spine so that they can do a back bend. All right, so, and then here is the common backache and things that go on with that. Here is some options for surgical repair. There have been, if the problem is in the joint itself, we have, science has created a lot of really good options. Now, rarely are you going to have a pathological condition inside the joint without having soft tissue external to the joint involved. You can have external external changes in the structure, the muscles, the bones, and all that, without having internal joint problems. So with massage, if the symptoms are related to the tissues outside of the joint capsule, then it's more likely that the massage can help with symptom management. If the problem is inside the joint, you're still going to get involvement of the structures outside the joint, around the joint. And it depends on what's going on there, on what you're going to do. So it can just be a symptom management idea. If the joint is lax, the tissues are going to stiffen and shorten to provide that stability. You have to be cautious about that. If you loosen that up too much, then that joint is unstable and it can move out of its protected movement and cause damage, increasing damage. At the same time, if that compensation is too aggressive, if you can increase just a little bit of movement in there for them, it may reduce the discomfort and it may produce a little bit more ease of motion for them. So here's your section summary and your chapter summary, your critical thinking segment. You know how to do all of these, and the multiple choice question. So this is the online course. You get it now. You know how these this online course, this orange course, pairs up with the chapters. And just like with the bones, the online course is really helpful. You'll find the same with the muscles. So just as we had with the chapter, we've got the joint overview, the joint movement, and the identification and palpation of specific joints. However, the pictures are different. So you're getting a novel repetition. Let's see if I can show you example here. Shoulders of the joint, or shoulders of the joint, joints of the shoulder. So here they are. It's a different stimulus for you to learn from. Different pictures. Shows you some pictures related to palpation here. It's chunked a little bit different, so that's really helpful. Shows you where it's at. Again, see the palpation point here. There's the scapular junction. And then we get to the elbow. So different than what you've got in the textbook. So do pay particular attention here. All the way through. All right. Very good. We'll move from now joints into muscles.